Okay, everybody, Dr. Ray Fidge from Vet Triage. We are continuing through this issue of JAVMA, January 1st, 2016. We are talking about liver biopsies in dogs. This is a short-term clinical outcome of laparoscopic liver biopsy in 106 cases from 2003 to 2013. It comes out of the University of Pennsylvania Veterinary School and the University of California, Davis in California. The objective is to describe the operative technique, complications, and conversion rates of laparoscopic liver biopsy in dogs and evaluate short-term clinical outcome for dogs that underwent the procedure. It's retrospective, so for those of you who watch this channel, when you have retrospective studies, right away you should think there's no standardization, which is a problem because they have 106 dogs, which would be a good number in the veterinary field for a study. However, with retrospective, it means every case has its own variriations to it. It's not standardized, so it kind of hurts the numbers. Procedures, they use either a single port or multi-port technique that we're going to go over here in a minute. And the laparoscopic liver biopsy specimens were obtained with a 5 millimeter laparoscopic biopsy cup forceps and grasp and twist technique. Prior to surgery, 27% of dogs had a coagulopathy, so a prothrombin time or a partial thromboplastin time that was greater than the reference range, regardless of platelet count. And then some dogs were thrombocytopenic, some had ascites, some received fresh frozen plasma transfusion before surgery. In all cases, biopsy samples collected were of sufficient size and quality for histopathologic evaluation. 2 dogs required conversion to an open laparotomy because of splenic laceration from initial port placement. 101 of the 106 dogs survived to discharge. 5 were euthanized due to liver disease and poor prognosis. Conclusions and clinical relevance. The single port and multi-port laparoscopic liver biopsy were found to be effective, minimally invasive diagnostic techniques with a low rate of complications. Results suggest that the laparoscopic liver biopsy can be safely used in dogs with underlying coagulopathies and advanced liver disease. 1 second. Okay, introduction. Other options include, for liver biopsy, fine needle aspiration, ultrasound-guided percutaneous core needle biopsy, ciliotomy, and minimally invasive laparoscopic techniques. Since 1972, laparoscopy has been used for diagnostic purposes in veterinary medicine. It results in less pain, superior visualization, fast return of function, shorter hospital stay, and potentially decreased infection rates compared with open surgical procedures. Single port laparoscopy reduces the number of ports to a single incision and has the advantages of less pain, faster recovery, better cosmetics compared with conventional laparoscopic surgery. Potential drawbacks to this technique include loss of triangulation, instrument interference, and increased technical difficulty. Triangulation is when you have 3 instruments in the pets, and so that hold on 1 second. You have 3 instruments instead of 2 or 1. So if you have 3, it forms like a triangle, and so you can get 3 different angles to what you're trying to visualize, and also it allows you to have 1 instrument for visualization, 1 for biopsy collection, 1 for manipulation. So that's what they mean by triangulation. It gives you a good 360 view of what's going on there. Now, the laparoscopic liver biopsy technique, it can visualize the region where the biopsy sample will be obtained, and you can also evaluate for excessive hemorrhage immediately following the biopsy collection. Risks inherent to liver biopsy include low blood pressure, hemorrhage, damage to viscera, peritonitis, hepatic emphysema. Patients with advanced liver disease can have ascites, coagulopathies, and thrombocytopenia, and may be at increased risk of complications and hemorrhage secondary to liver biopsy. Reported conversion rates from laparoscopy to an open laparotomy following a diagnostic procedure in dogs and cats have been reported to be as high as 21%. And so what conversion says, or conversion to open laparotomy, is when you go from this minimally invasive surgery to all of a sudden now you have a problem and you can't manage it with this approach, you have to convert the patient to open, which means you have to make a full incision now to solve the problem. A recent study found a complication rate of 7.5%. Okay, materials and methods. So they had a multi-port laparoscopic technique and a single-port laparoscopic technique. The multi-port laparoscopic technique involved a modified Hassan technique with a 6mm trocar cannula assembly for placement of a 5mm 0° or 30° telescope, insufflator tubing, which insufflated the patient to 8 to 12 millimeters of mercury with carbon dioxide via a pressure regulating mechanical insufflator, a second 6mm trocar cannula assembly that was placed 3 to 5 millimeters lateral to the ventral midline in the left or right cranial abdominal quadrant, and this trocar cannula assembly was inserted percutaneously with the aid of a sharp obturator or with a threaded screw-in tip port under direct laparoscopic guidance. We're not going to go into what all those terms mean. As for those of you who are interested in this, you'll know it, but I just explained the setup here for multi-port. All right. With single-port laparoscopic technique, they had three 5mm cannula supplied with the port. They were inserted to 3 corresponding cannula holes of a device with the aid of an accompanying 5mm blunt obturator. Heights of the cannulae were then staggered, insufflator tubing was attached, and the abdomen was insufflated to 8 to 10 millimeters of mercury with carbon dioxide with a pressure regulating mechanical insufflator. And so you can see the pictures here. This top one, this is the trocar cannula arrangement for a multi-port laparoscopic liver biopsy. And then this one here is a multi-trocar device for a single port laparoscopic liver biopsy technique. So one port for all the instruments. Okay, regarding the technique, they use a 5mm 0° or 30° telescope, a 5mm blunt laparoscopic probe. They tilt the patient laterally to the left or right and in Trendelenburg or reverse Trendelenburg position. So that implies whether or not the patient is going to be head side, the table is tilted upward with the head upward and the butt downward, or reverse with the head down and butt up, depending on what they need to do. You can imagine if you tilt the patient with the head up, right, then all the abdominal organs are going to come away from the liver, and so you have easier access to the liver. But if you tilt them the other way, all the organs go down to the abdominal cavity, and that lets you visualize the caudal abdominal region. So it just depends on what you're trying to do. Whatever needed to evaluate the complete evaluation of the liver. Then they collected 3 to 5 biopsy samples using 5mm biopsy cup forceps. They used they grasped the liver tissue with forceps and then twisted in a clockwise direction for 4 to 6 full revolutions on the instrument's shaft axis. And here is a picture of them using an instrument to grab the liver, and then they'll twist and pull. They'll twist it several times, then pull it to collect the biopsy. Results. Most common were mixed breed dogs, followed by Labrador retrievers. Median age is 84 months. Median weight is 22.4 kilograms. The median body condition score was 5 out of 10. Mostly spayed females. 25% with thrombocytopenic, so they had platelet counts that were low, either less than 178,000 platelets per microliter or less than 150,000 platelets per microliter, with a median count of 143 platelets per microliter. Overall, 26.6% were classified as coagulopathic. The prothrombin time was prolonged by a median of 15.7%, and the partial thromboplastin time was prolonged by a median of 16.7%. Most surgeons and internal medicine doctors don't worry about low platelets until they're either 30% below normal or around like 30 to 50,000. They don't really elaborate on that here unless I missed it. Same thing with the prolonged prothrombin and partial thromboplastin times. We don't really worry about it being abnormal. It's like, is it substantially abnormal? And I forget what the percentage, it might be 30% abnormal or whatever. That's why they were saying it's prolonged by a median of 15 to 16%, because even though they're prolonged, they may not be prolonged sufficiently enough for us to worry about surgery complications. Coagulopathic dogs were significantly more likely to receive fresh frozen plasma than were dogs without coagulopathy, so 60% versus 6%. Furthermore, coagulopathic dogs that received fresh frozen plasma had a significantly greater percent prolongation of partial thromboplastin time and a significantly lower platelet count compared with the results for those that had not received fresh frozen plasma. No dog with coagulopathy or thrombocytopenia had excessive hemorrhage. Surgical data. The multi-port laparoscopic technique was used in 99 cases, and the single port technique only in 7 cases. 13.2% of dogs had ascites during the surgery. Conversion to an open laparotomy only happened in 1.9% because of hemorrhage when they clipped the splenic capsule upon entering with the trocar cannula assembly. Both of these dogs that had conversion had the multi-port laparoscopic surgical approach used on them. And then regarding survival, 95.3% survived to discharge. Median total hospitalization time was 2 days. All right, let's go. Discussion. Results of the present study confirmed that the laparoscopic liver biopsy was safe and efficacious, minimally invasive technique for collecting liver biopsies. Intraoperative complications were rare at 1.9%. Other procedures you can consider for liver sampling are fine needle aspiration, ultrasound-guided biopsy, ultrasound-guided needle biopsy, and open laparotomy. Fine needle aspiration is fast, cost-effective, requires minimal sedation, low risk of hemorrhage, but it's less accurate, with an agreement with biopsies ranging from 30 to 50%. Ultrasound-guided core needle biopsy allows you to collect multiple liver lobes under heavy sedation, decreased cost, and has an agreement with needle biopsy, with a wedge biopsy, which is considered the gold standard for dogs and cats, at 52% agreement. So better than the fine needle aspiration, but still not very good. And that depends on the size of the needle gauge that you're using. In human patients, abnormal coagulation test results do not necessarily predict bleeding among patients undergoing invasive procedures, including liver biopsy. Although fresh frozen plasma is effective for actively bleeding patients with coagulopathies, there is limited evidence in people or animals that fresh frozen plasma will prevent hemorrhage when administered prophylactically. It is important to consider that fresh frozen plasma does not contain substantial numbers of platelets and is not indicated for the prevention of treatment of bleeding due to thrombocytopenia. Very important to note that. Yep. Prophylactic fresh frozen plasma is not clearly indicated for non-bleeding dogs with mild to moderate prothrombin time or partial thromboplastin time prolongations prior to surgery. The twisting technique was used here to allow for hemostasis by allowing vessel spasm as well as disruption of the subendothelial collagen to initiate primary hemostasis. For the dogs that had the single port technique, it reduced the number of laparoscopic ports to 1 incision, better cosmetic, less pain, faster recovery. Drawbacks include loss of triangulation, instrument interference, and increased technical difficulties. So you can imagine if you're trying to squeeze multiple instruments into one hole, they can do this like sword fighting thing, and that's what they mean by instrument interference. Ascites is considered a relative contraindication to scoping in veterinary medicine because it inhibits visibility. In humans, ascites is considered a contraindication for diagnostic laparoscopy because insufflation causes frothing of the fluid, which causes problems with visualization. A veterinary study described ascites as having a protective effect on the risk of conversion in that study. In this population, 13.2% had ascites. They removed the fluid with suction before diving into surgery. The results here support that ascites may not be a contraindication for laparoscopy. Given the electrolyte shifts in low albumin and decreased oncotic pressure that may occur with removal of ascites, some surgeons propose this fluid should not be removed, and the presence of ascites is another indication for scoping with advanced liver disease. I'm not sure I agree with that. You still have problems with abdominal distension from ascites. It causes pressure on the organs. It causes pressure on the diaphragm, which can affect tidal volume. It also can cause discomfort for the patient. If that ascites is actually causing inflammation to the peritoneal lining, that's a problem. Also, it's going to put more pressure on your incision, which can make for incision leakage and disruption of the incisions. That's also a problem. So, I'm not sure I entirely agree with that. And also, I do think that some fluid gets left behind no matter what, even if you try your best to suction it. So, I haven't seen this be a problem in removing the fluid, and I think probably because we don't remove 100% of it because it's impossible to do that. So I'm just not sure I agree with that thought. Splenic injuries are reported during initial abdominal access with scoping procedures and the establishment of pneumoperitoneum by both the Verez needle and the Hasson techniques. Previous evaluation of laparoscopic liver biopsy samples collected with a 5 millimeter biopsy cup forceps showed that tissue samples of 1 centimeter cubed is of diagnostic quality with 8 to 13 portal triads available for examination, and is compliant with recommendations in the human literature that 6 to 8 portal triads be available for adequate histologic evaluation. Another study reported the results of laparoscopic liver biopsy, including patients that develop anemia requiring a packed red blood cell transfusion, as having complications. Although post-operative hemorrhage and anemia caused by blood loss is a concern, it's difficult to say whether or not the transfusion was secondary to the disease rather than from surgery. And then finally, patients with liver disease may prove to be challenging anesthetic-wise because they have abnormalities in glucose metabolism, drug metabolism, coagulation, neurologic function, and ascites, all of which are complicating factors for the perioperative period. And that's it. So it's a pretty decent study. Obviously, you want more of a prospective approach to this, so there's more standardization, but it's a good number of dogs and very useful information. For veterinarians, just again, realize that if you don't provide scoping, at least give it to owners as an option. If there's a specialty center that does it, if it's better for the patient, and let the owner decide. And for pet owners, realize that there are other techniques you can do, especially for animals that are not as healthy for conventional surgery. But realize, of course, with any procedure, there's always going to be risks associated with it, and you have to defer to the surgeon as to whether or not they think this is the right technique for your dog or cat. All right, we'll see you guys in the next one. Take care.